moderate this session with Dr. Venkatesh Aiyagari, who is at present based in Dallas, Texas. And I know him through the WhatsApp group because he's an ex-NIMANS alumni. And he actually joined after I left. But he's very, very active on the group, and his comments are extremely good, and a lot of knowledge and a lot of insight. And he did his residency in neurology in NIMANS, and then again he did it in New York. And so that speaks a lot about his perseverance. And now he's a professor in neurological surgery, neurology, and neurotherapeutics, and director of neurocritical care. So he's mainly working in the ICU. Venkatesh, you don't see patients in the outpatients, I believe.
No.
So he's mainly in the ICU, and no better person than him to talk on cerebral edema and stroke, because he's done a lot of work in stroke, also in hypertension and in neuro ICU. So we couldn't have got a better person than him. So I hand over the floor to Dr. Venkatesh to talk on cerebral edema in stroke.
Good morning, everybody, and thank you so much, Dr. Echapuria, for the kind introduction, and for both Dr. Subhash Kaul and Dr. Sunil Gajre for asking me to speak on this topic. So what I'm going to do today is I'm going to divide my talk into three broad areas. First, I'm going to discuss the pathophysiology and the general principles of management of cerebral edema. After that, we will move on to the management of cerebral edema, specifically in acute ischemic stroke. And then we'll close with a discussion on the pathophysiology, the time course, and the management of cerebral edema in acute intracerebral hemorrhage. So we'll start off with a definition, and cerebral edema is defined as an abnormal accumulation of fluid within the brain parenchyma, which leads to an increase in brain volume. And if you remember from way back in pathology, cerebral edema is classified into intracellular edema and extracellular edema. Intracellular edema is again divided into cytotoxic edema, which is the classic edema we see in patients with acute ischemic stroke. There's also an osmotic edema, which you can see, for example, in metabolic conditions such as severe hyponatremia. And extracellular edema is again classified into vasogenic edema, which we characteristically see in tumors, and interstitial edema, which we can see in acute obstructive hydrocephalus. For the purpose of this talk, I'll confine my comments on just cytotoxic edema and vasogenic edema. In recent years, there has been an evolution on how we think about cerebral edema. For one, the term cytotoxic edema is being replaced by cellular edema because not all cytotoxic edema is due to toxin. And we now know that extracellular edema is a continuum. It starts off with ionic edema, which is an accumulation of protein-poor fluid in the interstitial space, followed by what would be previously known as vasogenic edema, which we now call a protein-rich fluid in the intercellular space. And finally, some people believe that hemorrhagic conversion of intracerebral infarcts, which is nothing but bloody fluid in the extracellular space, is also part of this continuum of extracellular edema. So this is a little complicated slide, and I'm going to try to walk through this. So the first point I'd like to make is that when we have cytotoxic edema, neurons, astrocytes, as well as the endothelial cells are all involved, and they all get swollen. But for various reasons, astrocytes are really the major players in cytotoxic edema. And in the center here, we have a normal astrocyte. surrounded by these green sodium molecules. And obviously the extracellular concentration of sodium is much higher than the intracellular concentration of the sodium. And the astrocyte manages to keep the sodium out by using the sodium-potassium ATPase pump. Next to that is a blood vessel, and you see these endothelial cells. And inside the blood vessel are some more sodium molecules, these orange protein molecules, as well as these red blood cells. And all of these are again confined within the blood vessel. Now, any severe cerebral injury, and especially in our context, acute cerebral ischemia, will give rise to depletion of ATP, and the sodium-potassium ATPase pumps don't work that well. And as a result, sodium follows the electrochemical gradient and enters the cell, and water and chloride ions also follow, resulting in cellular edema. Now, this results in cell swelling, but if you remember, we had said earlier that cerebral edema has to have the swelling and increase in the entire brain volume. Mere increase in the volume of the cell that's happening at this point is just shifting of fluid from the extracellular compartment to the intracellular compartment. So in order for true increase in brain volume to happen, this has to be accompanied by movement of fluid and sodium ions from the intravascular compartment into the extracellular compartment. And this cytotoxic edema actually forms the driving force, because now that these sodium molecules have entered the cells, there is now a gradient that forms for sodium to come from the intravascular compartment to the extracellular compartment. And again, there is diffusion of water leading to a net increase in the entire brain volume. So cytotoxic edema and ionic edema essentially go together, and they stay hand in hand. On the other side, injury also leads to activation of astrocytes and activation of microglia, which release a lot of inflammatory mediators. This in turn opens up the gap junctions between the endothelial cells, and this leads to escaping of the plasma proteins, as well as more water from the intravascular compartment to the extracellular compartment. And in extreme circumstances, the entire endothelial cell might be destroyed, leading to extravasation of red blood cells as well, and this is nothing but hemorrhagic conversion. Now let's talk a little bit about the important mediators of these mechanisms. First, we'll concentrate on the cytotoxic side. And here, there are three mediators that are particularly important because these are potential treatment targets for cerebral edema. The first is the aquaporin 4, which is concentrated at the astrocytic foot processes. And this actually forms a channel for water to enter into the astrocytes. The second one is the sodium-potassium chloride cotransporter. This is an interesting channel which is actually antagonized by bumetanide, which is a diuretic, which some of us may have used in the past. And this also helps sodium ions enter the cells. And the last molecule, or the last receptor, is the sulfonylurea receptor 1 related channel. And this is a very important channel because this channel is actually upregulated when the cells are deficient in ATP. So in conditions like cerebral ischemia, where we have decrease in the amount of ATP, this channel gets upregulated, and it gets upregulated not only in the astrocytes, but also in the endothelial cells, and facilitates transport of sodium. And we will come back to this receptor channel later in our talk. On the other side, again, when we talk about vasogenic edema, there are a whole host of inflammatory mediators which are implicated in the generation of vasogenic edema. Most important among them are the matrix metalloproteinases, VEGF, endothelin B, as well as other inflammatory mediators such as interferons, tumor growth factor, etc. And all these result in opening up of the tight junctions between the endothelial cells and allow extravasation of plasma proteins, thereby generating vasogenic edema. Now, in the last few months, there has been another important change in the understanding of cerebral edema. And this is a paper that is published in Science just last month, which talks about the role of the glymphatic system in cerebral edema. And this whole concept comes from the fact that if you think about a patient with an acute cerebral infarct, the core actually probably does not have any blood supply. And if there is no blood supply, what is the source of fluid and these sodium ions that give rise to cerebral edema? And the glymphatic system offers a possible explanation to overcome this paradox. And the theory is that an acute cerebral ischemic insult leads to spreading depolarization. And this spreading depolarization leads to vasoconstriction of these small blood vessels that occupy the Volkov-Robin space. And when these blood vessels constrict, this extra space that is there in the Volkov-Robin space gets filled up with CSF, and it's actually the cerebrospinal fluid which is the source of iron and water delivery. And there's also an important role for aquaporin 4 in this mechanism as well. Again, this is a very new theory, so there's a lot still to be learned as to how important this mechanism might be and what the therapeutic implications of this might be. Now let's talk a little bit about some of the basic principles of osmotic therapy, which is one of the fundamental ways in which we treat cerebral edema. So osmotic agents, by definition, increase serum osmolarity. And assuming that the blood-brain barrier is reasonably intact, they shift fluid from the interstitial compartment into the intravascular compartment. This, in turn, shrinks the brain and thus decreases intracranial pressure. There are other effects that many of these osmotic agents have, including lowering of cerebral viscosity, improving cerebral blood flow, potential antioxidant and anti-inflammatory effects, but we won't go into those details during this presentation. Now, these are some of the commonly used osmotic agents, at least in the United States. We obviously use Mannitol, that's available in concentrations between 15 and 25%. We use a lot of hypertonic saline, which is available in different concentrations, ranging from 3% all the way up to 23.4%.
Thank you.
We also use, or actually in the recent years, we have realized that hyperchloremia is an important risk factor for acute kidney injury. And to obviate that, we are now using a fair amount of buffered 3% hypertonic saline, which contains a fair amount of sodium acetate and decreases the chloride load and theoretically at least decreases the incidence of acute kidney injury. We do not have glycerol in the United States, so I do not have any experience with the use of glycerol for cerebral edema. And in this table, I've listed the relative osmolarities of the 3 commonly used agents in the United States. And as you can see, 20% mannitol is more or less equiosmolar to 3% sodium chloride. And here are listed some of the general principles when you decide to use osmotic therapy for a patient with cerebral edema. First, if you have an ICP monitor in place, for example, in a patient who has a traumatic brain injury, you want to start with the lowest dose that will be effective in lowering the intracranial pressure unless the patient is acutely herniating. The next thing is you need to be aware that as time goes on, the brain cells will generate idiogenic osmoles and increase their intracellular osmolarity. So the doses that are effective on day 1 will probably not be effective on day 2 and 3. And this is just because the brain is generating idiogenic osmoles and not necessarily because the underlying pathology is worsening. So as time goes on, you may have to progressively either increase the dose or use more frequent doses. And if you use osmotic therapy for more than 24 to 48 hours, again, because the brain starts generating idiogenic osmoles, you always want to taper your osmotic therapy and not to stop the osmotic therapy suddenly to avoid the risk of rebound cerebral edema. You always want to keep in mind that while giving the patient osmotic therapy, you don't, coincidentally treat them with hypertonic fluids, either in the form of dextrose water or giving free water through the nasogastric tube, because this kind of defeats your purpose of raising your serum osmolarity. And lastly, again, this is very important, especially when you're using mannitol, which is a reasonably powerful diuretic. You want to maintain euvolemia. The goal is to make them hyperosmolar, not hypovolemic. When we use mannitol for acute cerebral herniation, we usually start off with a rapid IV infusion of 1 to 1.5 grams per kilo. If you do not use ICP monitoring, then 25 to 50 grams every 4 to 6 hours is a reasonable dose. Some of the important side effects of mannitol to watch out for are electrolyte disturbances like hypo and hyperkalemia, hypomagnesemia, hypophosphatemia, as well as hemolytic anemia. Remember that mannitol will be a volume expander when given acutely, and you want to use it very carefully in patients who have a low ejection fraction, and we see it quite commonly in patients who have strokes. And you definitely want to avoid using it in patients with renal insufficiency because mannitol is excreted by the kidney and can accumulate in the blood in patients with renal insufficiency, and actually in some cases give you a hyperosmolar coma just because the mannitol you've given is not being excreted. So you'll see many textbooks and guidelines and review articles will recommend targeting mannitol to maintain osmolarity between 310 to 320 milliosmoles per liter. There's really no strong evidence to support this practice. In my practice, if needed, I routinely treat patients with much higher serum osmolarities than this, provided you make sure that all the mannitol you've given is excreted prior to giving the next dose. And the way we ensure that this happens is by calculating the osmolar gap before each dose of mannitol. The osmolar gap actually acts as a surrogate for a mannitol level because mannitol is an unmeasured osmol. And you can calculate the osmolar gap quite easily by asking the lab to do a measured osmolarity. And then you obtain a simultaneously drawn serum sodium, blood urea nitrogen, and glucose, and you calculate the calculated osmolarity. And the difference between the two will give you your osmolar gap. And as long as your osmolar gap is less than 20, you're okay to go ahead and give the next dose of mannitol. Now for hypertonic saline, the important point to remember is that about 0.7 ml of 23.4% saline, if you have that available, is equally osmolar to 1 gram of mannitol. So the commonly used doses for us are either 30 ml of 23.4% saline, or if you're going to use 3% saline instead, you can give 250 ml and they will all be equiosmolar. The advantages of hypertonic saline are that it can be used in patients with renal insufficiency. It's useful when volume expansion is desired, and it has less of a diuretic effect. And let's say you're giving somebody mannitol and at the end of 3 hours, your osmolar gap is still high, but the patient has an ICP spike and you want to give something else, you can actually alternate boluses of hypertonic saline with mannitol. The main disadvantage is that 23.4% saline needs central venous access, but again, in an acute emergency, it can be given intraosseously for at least 1 dose. What about giving continuous infusions of hypertonic saline and trying to target the serum sodium between, let's say, 145 to 150 or 150 to 155, whatever your threshold might be. Now, again, I'm not a big fan of this for reasons that are very eloquently expressed in this editorial by my mentor, Dr. Derringer. And he says that the case for continuous infusion of hypertonic saline is weaker, and this rationale is inconsistent with our understanding of the mechanism of action of osmotic agents. Firstly, the acute osmotic disequilibrium created by a bolus of hypertonic saline, which drives the movement of water out of the brain, is not created when you use a continuous infusion. And second, the creation of a sustained hyperosmolar state actually drives the compensatory creation of intracellular osmoles. And it also favors movement of solutes into the brain, especially in conditions in which the blood-brain barrier may be damaged. The clinical studies do not provide clear evidence of benefit, and the use of continuous infusions to create a sustained hyperosmolar state should be avoided pending further study. Well, if you do decide to use osmotic therapy with either mannitol or with hypertonic saline, is there a serum sodium number that you would be scared about? And this is important because in the medical and surgical ICUs, hypernatremia is considered to be an indicator of the quality of care. And hypernatremia has been shown to correlate with mortality in both medical and surgical ICUs. However, in neuro ICUs, we actually use hypernatremia as therapy. So this is a study that I did, and we looked at all our hypernatremic patients in our neuro ICU at Washington University. And we saw that both in patients who are on osmotic therapy and on patients who are not on osmotic therapy, as your serum sodium goes up, your mortality goes up. But it is only at levels of greater than 160 milligrams per liter of sodium that the hypernatremia becomes an independent predictor of ICU mortality. So when we use hyperosmolar therapy, either with mannitol or with hypertonic saline, we're very careful to try to make sure that we do not reach this number of 160 milligrams per liter. And lastly, which is better, mannitol or hypertonic saline? There are several articles that have looked at it. And while there may be statistically significant differences in intracranial pressure by a millimeter or two, in practice, provided you use equiosmolar doses, there does not appear to be a clinically relevant difference between these two agents. Now let me move on to our next topic, which is edema and hemispheric infarction. So again, for the purpose of this talk, I'll concentrate on MCA infarctions. And as all of you know, the MCA has three territories: a deep territory supplied by the lenticulostriate arteries, the anterior or the superior territory, as well as the posterior or the inferior superficial territory of the MCA. Now, from various registry studies, we know that if you have a large hemispheric infarction, which is defined by involvement of at least two of the three territories, mortality is around 20%. If you have a complete MCA infarct, which means you have involvement of more than 90% of the MCA and involving at least parts of all three territories, the mortality is 22%. And no, this is not a typo, and you can look this reference up if you want to confirm it. If on top of this complete MCA infarction, you now start having decrease in level of sensorium and or pupillary changes due to cerebral edema, your mortality approaches and exceeds 50%. And this off-coded figure of 80% mortality is in patients who have this malignant MCA infarction syndrome, which is a subset of deteriorating large hemispheric infarcts who actually need ICU admission for either respiratory failure or increased ICP. So just because somebody has even a complete MCA infarction does not automatically mean that their mortality is in the range of 80%. So how do we predict which are the patients that are likely to deteriorate. There are some clinical predictors, such as the presence of headache, nausea, and vomiting. Obviously, declining level of consciousness and pupillary dilation would indicate worsening cerebral edema. A high NI stroke scale is also a predictor of worsening, and the exact number varies from different studies, which is why I'm not going to give you a number here. There are also very important radiological predictors of worsening. On a CT scan, this includes early hypodensity of more than 50% of the MCA territory, a dense MCA sign, a pineal shift of greater than or equal to 5 millimeters within the first 2 days, an aspect score of less than or equal to 7, a DWI volume on MRI of more than 82 ml in the first 6 hours or more than 145 ml in 14 hours, and combined MCA and ACA occlusion on angiogram. You can also use this edema score that was published in Stroke about 3 years ago. And here you look at cisternal effacement, you look at midline shift, you look at the blood glucose, you see whether the patient has had a history of previous stroke and whether the patient got either IV TPA or thrombectomy. And you have different points that you give, and then you calculate a score. And in this paper, an edema score of greater than 7 had a positive predictive value of 93% in predicting neurological worsening. Now, what exactly is bad about cerebral edema and stroke, and what are some of the pathophysiological mechanisms behind neurological worsening? Well, obviously, first of all, there is local mass effect. And all of us, read Plum and Posner's book years ago, and there's a clear description of what we call a rostrocaudal progression when patients start developing cerebral edema. More recently, I think it has been quite obvious that more important than the downward herniation or the rostrocaudal progression, it is the lateral displacement and distortion of the midbrain that is probably the most important reason why patients with large hemispheric infarct get worse neurologically. In addition, you can also have contralateral hydrocephalus, and lastly, you can also have increased intracranial pressure, which further can decrease cerebral perfusion pressure and exacerbate your cerebral ischemia. So if increased intracranial pressure is important, should we be monitoring intracranial pressures in patients with large ischemic infarcts? And the answer is no. And this is why. So here are 3 case series of patients who've had deteriorating large hemispheric infarcts, who had ICP monitors in place and had intracranial pressures recorded at the time of deterioration. And you will see that in the huge majority of these patients, at the time of deterioration, intracranial pressure was normal. And clinical signs of herniation actually precede the rise in intracranial pressure. And what an intracranial pressure monitor might do is it might give you a false sense of reassurance that the patient's drowsiness might be due to other causes like fever or seizure or sleep deprivation, when in actuality, it is because of worsening midline shift. So we do not monitor intracranial pressures in patients with large hemispheric infarcts. Now moving on to treatment. So these are some of the broad category of treatment modalities that we use to treat cerebral edema and large hemispheric infarcts. And these include hyperosmolar agents, decompressive craniectomy, hypothermia, and some potential new therapies. Now, before I go on to treatment, it might be helpful to give a brief refresher on the modified Rankin scale for those of you who may not be familiar with this scale. So this is a scale that goes from 0 to 5. Some people include 6 for death. So 0 is no symptoms, 1 is symptoms without any significant disability, 2 is the status in which most of us currently are in now. We are unable to perform all our previous activities like go to the clinics and stuff, but we're still able to look after our own affairs without assistance. A modified Rankin scale of 3 is when the patient is able to walk without assistance, but there's still moderate disability and the patient requires some help. A modified Rankin scale of 4 is moderately severe disability. The patient is unable to walk without assistance and unable to attend to his or her own bodily needs without assistance. And a modified Rankin scale of 5 indicates a severe disability and a bedridden and an incontinent patient. So in general, modified Rankin scales of between 0 to 3 are considered to be fairly good outcome in stroke. So let's talk about hyperosmolar agents. So by and large, there is a lack of high quality studies that really look at how useful either mannitol or hypertonic saline are in patients with large hemispheric infarcts. The available studies that we have, especially the large ones, indicate that really mannitol does not seem to benefit the wide majority of these patients, and in some cases it might be associated with harm. Does that mean that there's no patient that should be treated with mannitol? No. There are also some smaller case series that report patients with large hemispheric infarcts that have been successfully treated with mannitol. Again, this is a paper by Charlene Ong published in Neurological Care in 2015. 13 patients with a median NIH stroke scale of 19, of which half of them survived with osmotic therapy alone. And there seems to be a good correlation between the NIH stroke scale and the rate of success with mannitol. And in her paper, if your NIH stroke scale was less than 20, you had almost a 60% chance of medical management success with osmotic therapy alone. This is one of my own cases from about 14 years ago, before hemicraniectomy was in vogue. And you can see, again, a large MCA infarct involving all 3 territories of the MCA, almost a 10 millimeter midline shift, treated with just osmotic therapy alone. And this is the scan 3 weeks later showing that the midline shift is all resolved. The patient did reasonably well and was discharged actually home. There is a theoretical concern when using osmotic agents that if you give mannitol, it will preferentially shrink the normal hemisphere. And because the blood-brain barrier is broken in the area of infarction, it might get trapped in the area of infarction and the midline shift might actually get worse. To address this, one of my mentors, Dr. Ed Mano, actually did a small study where he took patients with large hemispheric infarcts, got an MRI, gave them mannitol, and repeated MRI of the brain at 10 minutes interval after giving mannitol. And what he found was there's really no change in either horizontal or vertical displacement. The Glasgow Coma Scale score improved in 4 and worsened in 1. So this theory that mannitol might worsen midline shift does not seem to be borne out, although the caveat is that this study looked at only 1 dose of mannitol and not serial doses. Now, what about decompressive craniectomy? Now, there's been a lot of research on the role of decompressive hemicraniectomy, and several trials have been published within the last decade. And this is a list of a total of 8 trials. All of them are randomized controlled trials of decompressive craniectomy in large hemispheric infarcts. In addition to these 8 trials, there was a combined analysis of 3 of these trials, Decimal, Destiny, and Hamlet, which came up to a total sum of 93 patients that was published even prior to many of these trials actually being completed. For the most part, these trials included patients who were 60 years old or less, with a few exceptions. Destiny 2 had patients only that were above the age of 60, and Head First and the Chinese trial by Zhao included patients up to 75 and 80. The duration of time from symptom onset to inclusion in the study, again, varied between these trials. Most of them were within 48 hours, with the exception, again, of Head First and Hamlet, which enrolled patients up to 96 hours. Imaging criteria for most of them was involvement of either greater than 50% or greater than 2/3 of the MCA territory, different NIH stroke scale clinical criteria, different primary outcome parameters. Some of them were modified Rankin scale score of 0 to 3. Some of them had modified Rankin scale of 0 to 4. Head First looked at survival between 21 days. The main finding actually of almost all of these trials, with the possible exception of Head First, was that there was a significant reduction in mortality. Now, because these trials in of themselves were relatively small trials, it's probably helpful to look at meta-analysis and the results of the 3 combined trials. So this was a meta-analysis that was published in 2016 of 6 of the hemicraniectomy trials that enrolled patients within 48 hours. And as you can see, if you look at excellent outcome or favorable outcome, which is modified Rankin scale of 0 to 2 or 0 to 3 at 12 months, hemicraniectomy seems to be associated with a significant benefit, the relative risk being 2.81 to 2.06. But at the same time, if you also look at the chance of unfavorable outcomes, which is modified Rankin scale score of 4 to 5, that is also significantly increased to the order of a relative risk of 3.03 in patients who have gotten hemicraniectomy. Here we look at the modified Rankin scale scores of patients of all ages, patients who are less than or 60 years, and patients who are more than 60 years. So if you look at patients who are less than or 60 years of age, you'll see that hemicraniectomy decreases the mortality rate from 73% to 21%. So, and nearly 50% decrease in mortality here. And this actually does not lead to a significant increase of severe disability, which is modified Rankin scale score of 5. On the other hand, if you look at patients who are above 60, the mortality benefit is still substantial, but there is significant morbidity. So the way I'd like to think about it is that if you do hemicraniectomy in patients who are less than 60, for every 10 surgeries, 5 lives are saved. Of those 5 lives, 1 patient will have a modified Rankin scale of 2, 1 will end up with a 3, and 3 will end up with a modified Rankin scale score of 4. If you do the same surgery in patients above 60, for every 10 surgeries, 3 lives are saved, but no patients will end up with a modified Rankin of 2 or 3. 2 will end up with a 4, and 1 with a 5. And this again looks at age and also looks at what modified Rankin scale is acceptable. And if you take a modified Rankin scale of 0 to 4, then you have a higher likelihood of a patient accepting the outcome with less than 60, whereas for greater than 60, if you accept modified Rankin scale of 0 to 3, then it becomes a little bit more of a problem. So I'm going to skip over some of these slides in the interest of time, but just to say that for systemic hypothermia, it was in vogue earlier on prior to the hemicraniectomy era, but with recent studies, there appeared to be a high risk of pneumonia, and so we don't use it that much these days. There's also recent interest in using selective intra-arterial hypothermia while doing mechanical thrombectomy, And again, these are two interesting papers, and hopefully something might come out of that. In terms of newer therapies, I'll just talk about one agent, which is IV glyburide. And this IV glyburide is the one that I had mentioned before. It is a blocker of the SUR1 receptor channel. And this was studied in a phase 2 trial. It was a small trial that was prematurely terminated for the lack of funding. It did not meet its primary outcome measure of improvement in modified Rankin score, but there was a statistically significant improvement in midline shift. So this gives us some promise for future trials. Real quick about the acute stroke guidelines. The American Heart Association guidelines suggest the use of osmotic therapy and moderate hyperventilation for patients with acute severe neurological decline. They do not recommend hypothermia or barbiturates or steroids. They recommend hemicraniectomy in patients less than 60 years of age who deteriorate neurologically. In patients above 60 years, they say that it may be considered. The European guidelines are again similar. Consider decompressive therapy within 48 hours in patients up to 60 years of age, and osmotherapy to treat elevated ICP prior to surgery. Now, I'm a little reluctant to talk about cerebral venous thrombosis because you know way more about this than I do. But just to mention a few points, osmotic therapy has not been well studied. Astazolamide may help symptoms, but seems to be unlikely to change outcome. ICP monitoring and LP and ventricular drainage is a problem in cerebral venous thrombosis if your patient is being anticoagulated. The role for thrombolysis, either mechanical or chemical, is unclear. Decompressive surgery seems to be effective in preventing death in case of impending herniation. And the good thing about hemicraniectomy in decompressive surgery is that patients either die or they get better. And it does not seem to result, at least in the published literature, in significant amount of even moderate or severe disability. And even patients with dilated and fixed pupils in venous thrombosis have been reported to improve after hemicraniectomy. Now, real quick about intracerebral edema. I'm going to show you these two patients of mine. The first patient, large intracerebral hemorrhage. You see this patient scan on day 12. The hematoma is mostly absorbed. There may be just a slight amount of increased hypodensity around the clot, not much increase in midline shift. You see the second patient, another hypertensive basal ganglia hemorrhage. Again, this thin line of edema around the clot. But look at this patient's scan on day 10. The edema is significantly more, and there is a significantly larger amount of midline shift as compared to, for example, this patient. So the natural history and the incidence of perihematomal edema and cerebral edema is not very well studied and is a little bit of a puzzle. So this is a study by Chitra Venkatesubramaniam from Stanford, and she looked at 27 patients, all serially followed with MRIs on day 2, 7, 14, and 21. And here is the relative perihematomal edema. And you will see in a huge majority of patients, there is not much edema. And there is this small group of patients that seem to have a significant amount of edema. And unlike acute ischemic stroke, where you expect the edema to peak between days 2 and 5, here the edema seems to be between days 10 to 20, around day 15 or so. And the growth of the edema is maximum in day 1 to 2, and then starts tapering down. So again, to summarize, edema in or around an intracerebral hemorrhage appears to be biphasic. In the first phase, it starts within a day, peaks within 2 to 3 days. And then there is a second phase, which is seen in only a small fraction of patients, not always symptomatic, peaks towards the end of the second week and can last for as long as 2 to 4 weeks. The early edema that we see is thought to be nothing more than just plasma, because when the blood clots, the plasma is released, and that's the thin line you see. And there may be a small component of cytotoxic edema as well. After that, we have thrombin that sets up inflammation, inflammatory mediators, and breakage of blood-brain barrier, leading to vasogenic edema. And then after day 3, we have RBC lysis, and the iron is thought to be another important mediator of edema. Now, does this perihematomal edema have an effect on clinical outcome? Now, I've listed 21 studies of perihematomal edema. The green arrows indicate that this study showed that perihematomal edema was associated with a better outcome. The red arrows show that perihematomal edema was associated in these studies with a poor outcome. But in the wide majority of patients, the effect seems to be equivocal. Now, there are different targets that we can use to try to treat the cerebral edema around the perihematomal area. And these include hyperosmolar agents, steroids, blood pressure lowering, clot evacuation, and hemicraniectomy. Hyperosmolar agents and corticosteroids have not been found to be useful in the management of perihematomal edema. What about blood pressure lowering? It seems sensible that lowering blood pressure would decrease the hydrostatic gradient and potentially lower edema. This was actually looked at in a subgroup of patients enrolled in the Infarcts study, and lowering blood pressure does not seem to result in any difference in edema growth at 24 and 72 hours. Clot evacuation, on the other hand, does seem to help. This is a sub-study of the MISTY trial, which was a catheter and TPA-based hematoma evacuation study. And here, there was a significant difference in the edema volume in patients that had the hematoma evacuated as compared to those who didn't. Hemicraniectomy in intracerebral hemorrhage has not been well studied, and I'm happy to take questions on this, but suffice it to say for now that based on the studies that we have so far, mortality seems to be improved with hemicraniectomy. The effect on outcome is still yet to be established. Decompressive hemicraniectomy, again, if you look at its impact on perihematomal edema itself, actually appears to worsen perihematomal edema compared to patients that do not have this procedure. And lastly, coming to some of the other drugs and treatments that have that are either being studied right now or have had success in very small case series. Hypothermia is being studied for the management of intracerebral hemorrhage in these 2 trials. Celecoxib, which is a COX-2 inhibitor in the ICH trial, pioglitazone in the SHRINK trial, fingolimod, and a host of other drugs all have shown some promise in animal studies and hopefully will be tested in human studies soon. And I think I have about 10 minutes for questions, so I will stop now. And just to give you an idea of where I practice, this is the Zale Lipschi Pavilion of UT Southwestern. Our main neuro ICU is here, and this building hosts neurology, neurosurgery, psychiatry, and rehabilitation medicine. This is our main university hospital, and this is our other hospital, which is Parkland Hospital across the street, where we have another 12-bed neuro ICU. And again, thank you very much for your attention, and thank you again for the invitation to speak.
Thank you, Dr. Venkatesh. Overview. We can begin the question and answer session. there are 36 and we can start one by one. I'll begin by asking a question myself. Do you think that if the intracerebral hematoma bursts in the ventricle, the prognosis in those where it provided is the same? What is your opinion on that?
I think you were breaking up. Was your question that is intraventricular hemorrhage associated with the worst prognosis? Was that your question?
No, is it associated with a better prognosis? Or hematoma or a thalamic or a basal ganglia, if it bursts into the ventricles, is the prognosis better?
No, the prognosis is worse. And this has been studied in a number of studies that intraventricular hemorrhage is an independent predictor of poor outcome, and hydrocephalus is also an independent predictor of poor outcome.
Okay, thank you.
And that was the whole premise behind the CLEAR IVH trial, where the hypothesis was to actually try to instill TPA and try to evacuate the blood clot by liquefying the blood clot by using intraventricular TPA. Unfortunately, the trial turned out to be negative.
Okay, thank you. We go to the questions. There are about 46. Ahmad Subi asked, we have found better results with glycerol and mannitol in combination. Said that we don't use glycerol. Why? And any data on the benefit combination glycerol versus using mannitol alone?
Yeah, so, first of all, we do not have intravenous glycerol. I'm told that Europe has intravenous glycerol. In India, we did have a chance to use oral glycerol. In the US, oral glycerol is not used primarily for a few reasons. One is that it potentially causes diarrhea and the nurses hate it. And when you have an acute intracerebral edema, it's generally thought that maybe intravenous drugs will act more rapidly. And again, we do not know how long the effect of oral glycerol will last. And I don't even know whether glycerol given orally actually increases serum osmolarity, how to dose it, how much to give, how often to give. I'll just say that just hasn't been studied as much as the other agents, and we don't have it available here. So I really cannot comment about, whether it might be useful to combine it with mannitol or not.
We do use it. It is available as an IV preparation along with mannitol. Honestly, what is your opinion about?
No, I don't use that combination.
Particular reason why you don't use it?
I don't use it. I use either mannitol or 3%.
Yeah, that's what
we've not used glycerol. In between earlier, there were those problems with glycerol toxicity and things because it was contaminated. So I have not been using glycerol. I don't think very few people use it.
Yeah,
so some neurosurgeons just love it, but there's no evidence, proper evidence, and proper study. I don't know why they use it, and it's just done haphazardly. So actually, I don't think we should recommend it. Venkatesh, there is a question. When would you recommend decompressive hemicraniectomy? Would it be based on radiology, or would you wait for clinical signs to deteriorate? Or would you do it on the first day or the second day, or when?
Venkatesh, I want to add to this question. When would it vary whether the person has an infarct or whether he's got a bleed? Because bleed, the edema will go on worsening even later. So will your choice of things vary according to bleed or infarct also?
Also, you can add cortical venous thrombosis to that, because I have a few patients where have lives. So we can.
All right, so I think there are three questions. Let me take the first one, which is you have a patient with an acute cerebral infarct. How do you decide whether you are going to do thrombectomy or not? And if so, when are you going to do it? So I think one is if you do have MRI available, and I think most of us would get an MRI, there is reasonably good data to suggest that if, for example, anytime after 14 hours, if you get an MRI, and if your infarct volume is less than 145 ml, and this was shown in decimal as well, all patients that had an infarct volume of less than 145 ml did perfectly fine without hemicraniectomy. And obviously they were not randomized because that was the inclusion criteria. So if you have an infarct volume of less than 145, it is highly unlikely that that patient would require hemicraniectomy. Second, I usually will wait for some signs of neurological decline, and that might be even to the point of just the patient becoming drowsy or becoming lethargic. Because again, as I said, if you look at the registry data of just pure MC infarcts alone, just by looking at the size of the infarct in a patient that is wide awake and alert, it's hard for me to pull the trigger for hemicraniectomy, because if you look at just pure complete MC infarcts without decline in consciousness, and if you look at the sum totality, their mortality rate, is not as high to justify hemicraniectomy. So I'll wait probably for patients to become at least slightly sleepy. If hemicraniectomy is to be done, the sooner the better.
Venkatesh, just intervening. Suppose the patient is fully conscious, but the midline shift is more than 5 millimeters, say 7 to 8 millimeters. Would you wait still, or would you pull the trigger?
No, I think at that point I would probably try osmotic agents. And again, I showed you one case of mine who was like this. The patient had a 9.7 midline shift. We treated with osmotic therapy. The patient stayed wide awake throughout, and we did not pull the trigger. And the patient did fine. Of course, the caveat is that you should have a neurosurgeon that is available to do a hemicraniectomy within an hour or two. If you're in a setting where you do not have 24/7 neurosurgery available, then you might, intervene just on the basis of midline shift in a wide awake patient. In my setting, I would. And then lastly, if you look at the hemicraniectomy trials, you will see that the two trials that extended the interval to 96 hours, both did not meet the outcome measure. And the reason is not because hemicraniectomy is unsuccessful if done late. It is because that if the patient does fine for the first 2 days without needing a hemicraniectomy, the mortality after that is really low. And if you look at Hamlet, for example, they specifically analyzed patients who had their hemicraniectomy done between the hours of 48 to 96 and compared it to controls. And there is very slight difference. So for the most part, I think if the patient does fine in the first 3 days, the chances of that patient requiring hemicraniectomy later on is less. So again, to come back to the first question, if we do hemicraniectomy, we always do it, definitely within the first 48 hours, ideally within the first 36 hours. And after 48 hours, the patient, is maintain the level of sensorium, we may be able to get away without doing hemicraniectomy.
But if he deteriorates after 48?
Yeah, then, we would still definitely go ahead. But the chances of deterioration are less if the patient does fine in the first 48. Now, intracerebral hemorrhage is a whole different ballgame. And if you look at the evidence per se, right now, the picture is extremely muddied. We know that pure evacuation of intracerebral hematomas alone, if you look at the evidence, does not seem to improve outcome. The trials that have done hemicraniectomy, some of them do hemicraniectomy alone. Some of them do hemicraniectomy plus hematoma evacuation. Some of them do it in patients only with lobar hemorrhage, and the case series are small. And so it's really hard for me to give you an evidence-based recommendation of when to do hemicraniectomy, in whom to do craniectomy, to do hemicraniectomy plus clot evacuation, or just do hemicraniectomy alone. All I would say is that I think that hemicraniectomy is a life-saving operation in patients who get worse even in the setting of intracerebral hemorrhage, but whether the life-saving operation transforms a patient who would otherwise die to a patient who's severely disabled is yet to be seen.
Just yesterday, I had a patient who had a large deep-seated putaminal bleed, and the little minimal midline shift was flexing till 8 days. Now, on the 8th day, his edema has gone on increasing, and he's developed hydrocephalus, and now finally we've had to take him up for surgery. I mean, I thought like usually, like, you know, in fact, if we have got past the first week, probably we are through. But as you very rightly pointed out, it can worsen even later.
Yeah, we do not understand this pathophysiology of cerebral edema after intracerebral hemorrhage. You know, we do not know why only some patients develop it, and we do not know why in those patients that develop it, it can start late and it can persist, you know, and up to 4 weeks, which is like almost a month.
Even traumatic contusion can worsen quite late.
Yeah, they can.
Venkatesh, what is your view on EVD, putting in an EVD when there is an intraventricular extension of the bleed? Does it help, or it helps only in ICP monitoring, or how does it work?
So one is, you know, putting an intraventricular drain relieves the hydrocephalus. So if you have intraventricular hemorrhage, and if you have your third ventricle or the fourth ventricle obstructed with blood, that patient is going to develop hydrocephalus. So it definitely, you know, helps relieve the hydrocephalus. And in many of these patients, if your third ventricle and fourth ventricle is completely blocked, and if they have obstructive hydrocephalus, if you don't relieve it, they will die. So I think, you know, there is a role for ventricular drainage in patients who have reasonably small bleeds, who have significant intraventricular hemorrhage, just to treat the hydrocephalus alone. And again, it's, you know, in the CLEAR IVH trial, they went one step further and said, you know, we are going to randomize patients who have small intraparenchymal bleeds, but significant intraventricular bleeds, and randomize them to either getting intraventricular TPA to try to dissolve the blood clot and hopefully try to decrease their chances of getting a VP shunt, or decreasing the amount of time that the ventriculostomy has to stay in place, versus just giving them placebo, which is saline intraventricular injections. And in that trial, mortality was decreased in the group that got the intraventricular TPA, but there was a significant increase in morbidity. So the end result was that no significant difference in a modified Rankin scale of 0 to 4. So we do put in intraventricular drains for patients with ICH with hydrocephalus, but just to treat the hydrocephalus itself.
One question, maybe can you talk about high dose dexamethasone in ICH? Any trials being designed or?
So the previous trials have all been negative so far. And what they have shown is it actually increases mortality. Now, again, the caveat I will tell you is that all these trials have used dexamethasone early on, you know, within the first 2 weeks. And if we're pointing out the fact that, you know, cerebral edema and intracerebral hemorrhage can occur late, you know, in the second week, third week, fourth week, there really have not been any trials that look at delayed use of steroids. So the answer is we do not know, but the current evidence does not support the use of steroids for intracerebral hemorrhage.
Venkatesh, this using these osmotic agents, do you use it as a temporizing measure, or do you use it as treatment for maybe few days, or just, you know, prior to surgery, just before you're waiting? How does this play out?
Yeah, I think, you know, what I tell my residents is when we use osmotic therapy, we imagine that there's a water tank on the top of your house, which is leaking water. And osmotic therapy is a bucket that you have, and you're catching just the water that is coming and you're throwing it out. And the two things have to happen for you to actually get out of this problem. Either you have to close the hole in the water tank, or all the water in the water tank has to get depleted. So what osmotic therapy is essentially trying to compete with the forces that drive in water. They do not alter the natural course of the disease. At best, they are temporizing measures. So usually, in the situation of infarcts, we will use osmotic therapy just with the hope that, once the peak period of edema subsides, then we won't need it anymore, or we'll use it just a dose prior to taking the patient to the OR for hemicraniectomy. Now, we use osmotic therapy mostly in the situation of traumatic brain injury. And again, here, the issue is to try to use it to just keep the ICP under control till the point that the brain's natural healing mechanisms, whatever they might be, ultimately, reverse the process that's generating the edema. So it's always essentially, it's like using paracetamol to treat fever.
Yeah. So that clarifies. Another interesting point that you made was the evolution of the MCA infarct from just being an infarct and mortality being, say, 17 or 15% and rising to malignant MCA where the mortality was 80%. How does this transition happen? Is it only dependent on the size of the infarct or something else?
I think it's partly size of the infarct. It's partly, other vessels also being potentially involved, either the ACA being involved or sometimes the PCA being involved. Sometimes, if you have more space, white sulci, you might be less at risk to develop this kind of malignant phenomenon. I don't know if collaterals have a role to play. So again, it's unclear as to why some people have this kind of malignant progression and some others don't.
Even after failed mechanical thrombectomy, there are many people who do hemicraniectomy rather early. Even if the mechanical thrombectomy fails, do you think the rates of doing hemicraniectomy have come down in the era of mechanical thrombectomy?
Offhand, I don't know if I can answer that question, but one would think that, if with the success of mechanical thrombectomy, you should be theoretically seeing a lesser number of large complete MCA infarcts. In many cases, even if you're not able to salvage the entire MCA territory, you're probably able to salvage a significant part,
Exactly.
and at least that might obviate the need for hemicraniectomy.
So, I have a feeling that our rates of doing hemicraniectomy have come down in the era of mechanical thrombectomy. Even if you're not able to achieve full recanalization, even partial recanalization sometimes, prevents the patient going into hemicraniectomy. I don't know if this is true, or you agree with that or no?
Yeah, no, I think I do agree with you. I think that's a good point.
Yeah. Pawan, any more questions? We can't hear you.
I think most of the points have been covered very nicely, and I think it's very important to understand what is the mechanism of this edema in large infarctions. So, do you think that obstructive sleep apnea or something like that also might be one of the factors which might be increasing the cerebral edema?
Again, if you have obstructive sleep apnea, then, theoretically, if you have CO2 retention, CO2 is a vasodilator. It will increase your cerebral blood volume. It will, potentially at least increase your intracranial pressure. So it's possible. I'm not sure it's been proven yet.
Some comment on hyperventilation, Venkatesh?
That's a very interesting question. So I think acutely hyperventilation is very, very helpful in lowering the intracranial pressure. The problem with hyperventilation are two. One is that it is a temporary solution. So, long-term hyperventilation actually worsens outcome. So it's very helpful if you have a patient who has, developed signs of acute herniation, has blown a pupil, or has an acute ICP spike. Hyperventilation is very helpful, provided you have something as a backup on what you're going to do next, whether it be a dose of mannitol and then call the neurosurgeon and take the patient to the OR. Long-term hyperventilation is not very helpful. And the other interesting point about hyperventilation is that one of the reasons why we worry about increased intracranial pressure is that increased intracranial pressure lowers cerebral perfusion pressure, and lowering cerebral perfusion pressure actually causes cerebral ischemia, which is what we're worried about. Whereas when we're doing hyperventilation, we're actually causing vasoconstriction, because that's the way hyperventilation works, by to lower the ICP, which is by causing vasoconstriction and thus lowering your cerebral blood volume. So in the long term, hyperventilation will end up doing the exact thing that you're trying to avoid. So helpful as a short-term measure, not good for long-term.
Venkatesh, there is another question. You talked a little bit about hemorrhagic infarction and parenchymal hemorrhage following thrombolytic therapy as a separate type of. So is there any difference in management of hemorrhagic infarction, or it's the same like an infarct, or would you manage it slightly differently?
We don't manage it any differently.
You don't?
No.
How do you manage parenchymal hemorrhage, symptomatic ICH after thrombolysis? Okay,
so that we try to correct the coagulation parameters the best as we can. The guidelines would suggest that you check a fibrinogen level, and if the fibrinogen level is less than 200, you give them cryoprecipitate. We check the coagulation level. We don't do anything significantly more than that. Obviously, one assumes that the blood pressure is already under control. So other than replacing coagulation factors, we don't do much more. Sometimes the question comes up as to whether these patients should ever be taken for surgery or not. Our neurosurgeons basically throw a fit if you ask them to take a patient who's gotten TPA and has bled in the brain, you ask them to take the patient to neurosurgery. But that being said, there are reported cases in the literature of patients getting TPA for myocardial infarction who've had intracerebral hemorrhages, and those hemorrhages have been successfully evacuated. So I think in my career as a neurointensivist, I can recall only probably one patient who got TPA that we could convince a neurosurgeon to take the patient to the OR for a clot evacuation. For the rest, we just replace their clotting factors if there is an abnormality detected.
So one of the members wanted to ask about injection furosemide or Lasix for treatment of edema. Can you comment on that?
Yeah, it's, in of itself, it's not very helpful. Some people use it in combination with mannitol. Theoretically, it might have some benefits. There are some studies that report that it might decrease, CSF synthesis, just like astazolamide does. Again, there are really no randomized studies comparing mannitol alone with mannitol plus Lasix. I personally don't use it.
Venkatesh, how would you manage a cerebellar hematoma or a cerebellar infarction with brainstem compression?
Yeah, so in general for cerebellar hematoma, we still follow the guidelines, which is that as a ballpark, if the hematoma is greater than 3 centimeters in diameter, and or there is compression of the fourth ventricle, we would take the patient for surgery and have the hematoma evacuated. We usually would also put in a ventricular drain because these patients often have obstructive hydrocephalus. Now, if you look at the latest AHA guidelines, they recommend putting a ventriculostomy first and then take the patient to the operating room only if the patient does not benefit from the ventriculostomy. We haven't done that yet. In our experience, most of the time we would put in a ventriculostomy and take the patient to the OR.
Yes, so you know, those guidelines were a little disturbing because they said you put in a drain first and then you do decompression.
Yeah.
So, you know, we actually were doing decompression before putting in the drain.
Right. We usually do both at the same time. I don't remember, you know, many cases where we have put in drains without taking the patient for decompression. And I am, you know, very, very scared of the posterior fossa. The posterior fossa does not give you any time. And there are patients where we see that, you know, 1 minute they're fine and talking, and the next minute they're completely apneic and their blood pressure is, you know, undetectable. So I'd rather, you know, be safe than sorry, and our surgeons feel that way as well. So we prefer to, you know, take patients for decompression if the patient has obstructive hydrocephalus or, you know, even radiological signs of brainstem compression.
So one of the questions is in the venous sinus thrombosis, some patients only have raised ICP presentation with no localizing problems, and some have only like a cerebral venous thrombosis kind of presentation. Why there's so much of variation? Any idea upon that?
I think the cerebral venous anatomy is very, you know, heterogeneous. I think it's much more heterogeneous compared to the arterial blood supply. That may be one explanation.
Okay.
Venkatesh, do you, sometimes we used to, in a person who's borderline with a bleed, sometimes we do repeated lumbar punctures and you get a little reddish CSF coming out and the patient seems to stabilize at times. Somebody who is not yet requiring an EVD. Do you think that is a good option in someone who has an intracerebral, intraventricular predominantly bleed?
I don't know. That's not been my practice. So, you know, I haven't seen I haven't seen studies of intraparenchymal hemorrhage with intraventricular extension being treated with LPs. I can tell you that for patients who have subarachnoid hemorrhage, you know, people, many of these patients have hydrocephalus, you know, many a time because the arachnoid granulations are all clogged up with blood, and those patients can sometimes be treated with repeated LPs and sometimes be treated with just a lumbar drain instead of placing an intraventricular drain. So, you know, theoretically, I guess it's possible.
Yeah,
I haven't seen any studies of, repeated LPs in patients with intracerebral hemorrhage.
I think this, I first, we did it when I was houseman with Dr. Singhal. And we had tried it years back. And sometimes it works. I don't know.
But would you do that in subarachnoid hemorrhage to remove all the blood, and, you know, does it decrease the risk of vasospasm or deterioration?
No, it does not decrease the risk. I mean, again, it does not decrease the risk of vasospasm. It will treat hydrocephalus if it is a communicating hydrocephalus.
Venkatesh, is there any role for a combination of 3% saline and mannitol?
Yeah, so again, as I mentioned, you know, there'll be times when, let's say, you know, you give a dose of mannitol and then, let's say, you know, 3 hours later, you have an ICP monitor and now the ICP is 30, but, you know, you get an osmolar gap and you find out that the osmolar gap is 40, so you cannot repeat a dose of mannitol. So at that point, you know, you can give 3%. And there have been cases, especially in traumatic brain injury, where we will give mannitol every 6 hours or every 4 hours, and also give, you know, either 3% or 23.4%, 4 hours or 6 hours, so that every 2 to 3 hours the patient gets, you know, either one or the other. So, you know, you can try a combination of both as well.
I want to phrase it this way, that the majority of neurologists in India don't have access to ICP monitoring, and they want to buy time before they can get hold of a neurosurgeon to do me. So in that situation, would it be better to give only 3% or would it be better to give mannitol and 3% together?
I think again, there depends on what drug you're comfortable with and what doses you're comfortable with using. So my argument would be that why not just give a bigger dose of one drug instead of combining the two drugs. So again, monotherapy is probably better if you can get away with it instead of using two drugs. So instead of giving 25 grams mannitol, why not give 50?
But there are no trials comparing one trials where you have used only 3% or you have used only mannitol and where you have used the combination?
There are trials comparing one with the other, but there are no trials comparing one against a combination.
Okay, so that's something which we Indian neurologists and of course, somebody has asked about Diamox. Any role of it?
Again, other than in the situation of cerebral venous thrombosis, it's not much of a role. It is a very weak agent to decrease intracranial pressure. It possibly has an effect in decreasing CSF synthesis, but it's not a very powerful osmotic agent at all. So, we use it, if at all, in the setting only of, venous thrombosis. And that too, only in those patients who are either complaining of headache or have visual symptoms, not in patients who are becoming sleepy.
A few questions left, but mostly they're repetition.
I think we are running out of time, Sunil.
I think we can call it a day.
Yeah, it's late for him.
Yeah. Venkatesh, actually, we would be meeting right now in Toronto. Meeting hadn't been cancelled, and last year and it was a great pleasure to thank you. And if there are any further questions, we would be and you can to me or Nasli or Ichapu or Kothari.
Thank you, Venkatesh. Thank you, Nasli. Thank you, Pawan. And of course, thank you, Sunil. It was a very nice session, very interactive. And we look forward to calling Venkatesh again. Thank you.
Yes, Venkatesh, thank you very much. A lot of questions and a lot of clarifications. Thank you so much.
Thank you.
Bye.
Thank
मी येतो खाली झालं एक मिनिट खाली